This is my topic for today's presentation. That is how we manage the incipient carious lesions. Incipient carious lesions, we all understand that is an early carious lesion, that is a non-cavitated lesion. And okay, that's wonderful. Yes. This is my topic for today's presentation. That is how we manage the incipient carious lesions. Incipient carious lesions, we all understand that is an early carious lesion, that is a non-cavitated lesion, and it is a subsurface decalcified lesion. So whatever name we give, so that is what is incipient carious lesion. So with this webinar, what we are going to learn today, I will try to make you understand what is the latest thing about the caries process and what are the ways to detect the caries in early phases. And then what type of non-restorative, non-invasive or a micro-invasive treatment can be used to arrest or the reverse of existing non-cavitated incipient early carious lesion in adults as well as children. Because this webinar was not particularly for pediatric dentistry, so I have done a little bit of modifications to include everyone, all age groups in this webinar. So before we go into the details of management, let's discuss something about the latest guidelines, latest theories of dental caries. In the past, we always talked about dental caries as no doubt a multifactorial disease in which there is a decalcification and there is a disintegration of the hard tissues which lead to cavitation. But when we went into detail of the biofilm, the plaque, and then we realized that the modification of biofilm is very, very important if you want to arrest the disease. So the most important factor in dental caries is a biofilm. And biofilm, which is mediated, which is derived, which is modified because of presence of sugar in the diet, and it is a multifactorial entity. This is not at all related to only the tooth, to the diet, to the bacteria. No, there are multiple factors which are responsible for causing caries. Apart from these four factors, three factors, we have saliva, we have the time, we have patients' own psychology, we have economical status, we have systemic diseases, we have availability of fluoride into the drinking water or a systemic fluoride. So many. There are multiple factors which lead to dental caries. So this dental caries is a dynamic disease. Why dynamic? Because it is not a continuous, it is not a unidirectional process. It is a bidirectional process. So anytime there could be a healthy change, there could be an unhealthy change in this process, depending upon the factors which are available. Whether those factors are harmful, it will lead to progress of caries. And if those factors are not harmful, those are beneficial factors, then it will lead to stop of the caries process or even arrest of caries process. So this is a phasic decalcification. It is not a continuous decalcification. There are phases of decalcification and recalcification, which ultimately leads to the end result could be arrest of caries, stop of caries, or more resistant enamel, or a cavitated tooth surface. So it all depends upon which phase has overpowered. If a phase of decalcification has overpowered, it will lead to cavitation. If a phase of remineralization has overpowered, it will lead to arrest of caries process. So this is purely a biofilm mediated disease in which biofilm is kept on the top. So we just need to modify the biofilm. And apart from that, other factors which are responsible for recalcification of a decalcified enamel. So in this carious process, the components may be acting upon the tooth surface. There will be components which act upon the individual. It varies from one patient to another patient. For the tooth surface, very importantly, we have saliva, because if any deficiency of saliva is there, it can lead to decay, because saliva itself has lots of minerals. It has a buffering capacity, it has a cleansing capacity, and apart from other antibodies and all that. So saliva plays a very, very important role. And biofilm we have already discussed, and diet. If there are more number of exposures of sugar, the diet is more cariogenic, it leads to decay. And then presence and absence of right dictates the carious process. Then the factors which act upon the individual level, it varies from one person to another person, is the behavior of the patient, the knowledge of the patient about oral hygiene measures, knowledge of the patients about the carious process, knowledge of the patient about the diet, right? And then the attitude of the patient, the education level of the patient, the socio-economical status of the patient, as well as the income of the patient, because all these factors are responsible for carious process. And whatever the cavitation we see in a patient mouth is the symptom of the disease. It is not a disease. Caries is a disease. Cavity is a symptom of caries. So when in the past, when we used to treat a cavity, what we used to treat? Just the symptom of the disease, not the infection itself, right? And for example, patient is having a typhoid. In typhoid, patient is having abdominal pain. Patient may be having a fever, right? What a physician gives a crocin for the pain, a crocin for the fever, and maybe a drotaverine or any antispasmodic for the abdominal pain, but doesn't treat the infection which has been caused by the bacteria. Then what will happen? Patient is not going to get relief. Patient's condition is going to worsen and worsen and worsen. And same is for the dental caries. In the past, we always believed in drill and fill. We just used to look at the cavities, and we just need to look at clean the cavities and fill the cavities and send the patient off, but not after knowing in detail about the biofilm, about the factors which are responsible for caries. Now we want to heal, we want to seal later. So we want to heal the carious lesion which has started. We want to stop the carious process which has started. We want to diagnose it at very, very early phase which has started. And that is the reason the view from drill and fill has changed to heal and seal. Now, this is a beautiful diagram which was there in Operative Dentistry Journal in 2016. We can see the biofilm could have a physiological fluorus. The biofilm can have a pathological fluorus. Now, which factors are responsible for this change? The major factor is the diet, the fermentable sugar. No doubt the oral hygiene is there, the host defense is there. So all these factors can modify the biofilm from pathological flora to the physiological flora. And same factors can change the biofilm with the physiological flora to biofilm with the pathogenic flora. So now when the bacteria are there, the pathogenic bacteria are there, and there is availability of fermentable carbohydrates, the oral hygiene is poor, which leads to cavity demineralization. And if this demineralization is allowed to go on, what will happen? There will be sign and symptom of the disease, that is cavitation. But we want to stop this decalcification. We don't want that this demineralization should continue. We try to revert the factors like fluoride, we provide calcium, we modify saliva if possible, we go ahead with oral hygiene instructions, we increase the host defense, and we change the diet of the patient. So all these factors lead to remineralization of the decalcified lesion. So that is how we can anytime revert a phase of decalcification to recalcification. Now, we do not talk about the caries cavity management. We talk about the caries management, right? We do not talk about how to fill the cavities, but we talk about the caries management, the full caries management. In that plan, there are few factors, few important goals which we have to achieve. That we want to prevent the onset of caries across the lifespan. We want that the people should not have caries throughout their lifespan. And there could be two types of interventions. One will be the patient level intervention, which is in general we want to do for that patient. And that intervention is to re-establish the mineralization balance. Whatever the decalcification is going on into the tooth surface, that has to be reverted back. And that is at a patient level. Then at a lesion level, now we know that the lesion is there or lesion can be formed. Then what we need to do, we plan certain non-restorative or non-surgical interventions. Because now we are physicians. With the passage of time, the dentistry, especially the caries management plan, has changed from surgical to a physician way, the medicinal way of treating the caries process. That is what is. So at a lesion level, we try to do non-restorative or non-surgical measures. And if there is a cavitation which is already formed, then we try to treat the lesion with a minimal invasion or with a minimal invasive treatment. That is what is the current plan for in caries management. Now, in all these things, what important is to see what is the risk assessment of that patient. How much is there is a risk of development of caries in that particular patient, and that is that only we can come to know if we know the detail of that patient, not by just looking at the cavities, like number of cavities. We cannot. We need to go into detail of the patient, about the dental history, about the medical history, about the socioeconomic history. So all these factors are important, whichever factor which we have discussed before. All those factors are important to know, and then we can plan the treatment for that particular patient. Now, why caries risk assessment is useful in a caries management of dental caries, clinical management of dental caries? Because if you know the risk of that patient toward the caries, we can know the lesion activity. Because if you know the patient is not at all prone, everything is fine, then even if the lesion is there, and we can know the lesion is not very active, the progress of the lesion is not very fast. And then if we know the degree of risk, then we can plan that according to we can plan how intense treatment plan you need for that patient. It could be lots of things we need to do for that patient, or it may be a simple measure. So intensity of treatment plan and how frequently you need to call that patient can be customized if you know the risk assessment of that patient. So you need to identify what has led to this caries, which factor is responsible for dental caries. And if you know how much is the risk involved, you can formulate best restorative treatment and care for that particular patient. And then you can overall assess what will be the prognosis of your treatment. If I know my patient is having such a problem, because of that he cannot maintain oral hygiene, because of its behavior and attitude he cannot modify his diet, so I know whatever the best treatment I give to that patient, the prognosis is not going to be good, right? So when you recall that patient on a frequent visit, you can check how effective your treatment plan is, how effective it is. Because with the subsequent visit, if you find the same etiological factor responsible for that patient which has led to the caries, then you can very well understand that efficacy of your treatment plan is not there. But if you see, yes, whatever the etiological factor was there, and you are able to remove that factor, that means your caries management plan was effective. So that is the reason risk assessment of that patient is very, very important. Now, since so many undergraduates and postgraduates are watching or maybe watch this webinar later, because that's what Dr. Malik has informed me, that all third year and final year and interns of Pakistan dental students, they all will watch this webinar. For them, a few new things are there. So this is a new cavity classification by G Mount. I will share a document also with you from which the reference has been taken. So because we all followed a GB Black classification, but now we have changed our ways of classifying dental caries. So this classification is purely based upon the site and the size. So whatever the size of the cavity is, and whatever the site of the cavity is, a proximal or occlusion or a buccal surface, so accordingly this classification is. And then this is the article. You all can download this article, and you can know about the detail of this classification. And then this is a bit of detail, like a patent fissure caries, contact areas, and cervical. And this is 1, 2, and 3. And 0.1, 0.2, 0.3, 0.4 is according to the severity of the cavitation: minimal, moderate, and large, and extensive. So if you know it's a 3.5, that means there is extensive decay at the cervical portion of the tooth. Then we have international caries detection and assessment system, that is called as ICDAS-2. It was ICDAS-1 also, but this is ICDAS-2. This is a simple explanation of ICDAS-2 system of classifying caries, and this is with the direct visualization of a carious lesion. So whenever we examine a patient for dental caries, always examine in a dry tooth, in a direct light, in a good light, and using good vision. You can even use magnification for looking at the teeth for detection of caries. Never ever use an sharp explorer for looking for the lesions, because what happens if we are using sharp explorers for even maybe a proximal lesion or for a occlusal lesion, what happens, we know from our knowledge about the dental caries, that initiation of decalcification is always subsurface. The surface is always intact. And if we use explorer, what can happen? We can break the intact surface and we make a cavitation. And we don't want that cavitation to be formed, because now we can reverse that lesion. We can make that tooth more stronger, and we can just repair that lesion without any non-invasive treatment procedures. So that's why we should always examine the teeth in a good light, in a dry tooth, and a good vision. Maybe you can use a magnification, maybe a loop or a microscope. That depends upon what you have. But never ever use a sharp explorers. Always a ball point probe you can use, not the sharp one. Then this is this is the detail of that, this ICDAS system of classification. You can all get this beautiful photograph in this journal, Dimension of Oral Hygiene, September 2011. And this, according to this, you can see from ICDAS 0 to ICDAS 6, there is from no disease, then minimal disease, initial lesions, moderate lesions, and then extensive and lots of extensive lesions. So this is according to the staging of lesion severity, right? And then you can see on the downside, for ICDAS 0, no treatment is needed. And then we go ahead with remineralization, then arrest of the lesion, then sealants, minimal surgical, traditional surgical, and in case of extensive, we go ahead with endodontic treatment, and then if it is not successful, we go ahead with extraction of the teeth. This is how this classification system can detail you something about. And then we have another classification system that is by Gomes, J. Gomes. And according to that, we have a radiographic classification of the lesions. So when you take a X-ray, a bite wing X-ray or intraoral periapical X-ray, and you can see a the radiolucency present in the coronal enamel. And then for the proximal lesion, if there is no radiolucency, that is E0. And if there is an outer half of the enamel is radiolucent, that is E1, inner half E2, D1 is just crossing dentino enamel junction. If it reaches to the middle, it's D2, and inner half of the dentin is D3. Then this is another classification system, you all must read about it, is the American Dental Association Caries classification system. So what they have done is they have collaborated all these together, like a clinical examination, then about the dentine, infected dentine, whether present or not present, and then there is a IGDA system of classification, then a radiographic presentation. So they have clubbed it together and made this American Dental Association Caries classification system. So you all can read. Now, these non-cavitated carious lesions, what these non-cavitated carious lesions are, the surface that appears intact without any clinical evidence of cavitation, but there is a radiolucency present if we look at for the proximal lesions, right? And even for the occlusal lesions, there could be a radiolucency present, there could be a decalcification, but the surface will appear intact. You won't find any cavitation onto the surface. Now, this is another plaque index which is for you to understand, and it is very important when you examine the patient for dental caries, and especially for the occlusal surface, because we have another index for the proximal surface, and this is for the occlusal surface. Now, suppose you suspect a carious lesion present onto the occlusal surface, right? And then you find a plaque, lot of plaque, maybe index 2 or index 3. Then you can suspect that this lesion could be an active lesion, right? And there is a already we have given you the detail, like how we check the plaque for this index, that's called as visual occlusal plaque index. And according to this index, if there is no plaque present, by gently running a dental probe, gently, do not force the probe, because that's what we have already discussed before. If we force the probe, we may be fracturing the intact surface layer. So gently probe, gently and carefully run a probe over the occlusal surface, and if you find a dental this plaque present over the occlusal surface which is visible with naked eye, then you can suspect the lesion to be a active carious lesion, because we know a biofilm can be responsible for this dental caries. Now, there is another index that is called as papilla bleeding index by Sexer and Willeman. And according to that, there are 1, 2, 3, 4 grades. I'm not going to go into what all these scores are, but for me, if I am examining the proximal surface for dental caries, the important thing is, if I am finding a bleeding after a slightest provocation, that means it's a sign of inflammation. And sign of inflammation means because inflammation is because of the biofilm. And if there is a suspected proximal carious lesion and inflammation of gingiva and papilla is there in that particular zone, that means the carious lesion is active. Then we have this already, I think we have discussed about, and this is beautiful system that is called as International Caries Classification and Management System. This came after IGDAS-2. So according to this system, we have few important things to understand. One is the history of the patient, which we have already discussed. Then we have a classification. Classification doesn't mean class 1, class 2, class 3. No, classification means what is the stage of caries and how active the carious lesion is. And accordingly, we make a plan for that particular patient to manage that carious process. And that plan is always personalized, customized according to that patient for the prevention of caries, then control of caries, and then preserving the tooth. Preserving the tooth means whether the tooth has to be preserved with non-operative care. If at all operative care, then it should be minimal invasive, and it should not be invasive for that patient. So we want to respect the dental tissues. We do not want to lose the dental tissues. And that's the reason with the minimal invasive way, we want to treat the carious lesions now. And according to this system, International Caries Classification and Management System, first of all, we look at the patient, we collect the personal data, we go for the history of the patient and all that we collect. And then we check for the lesion detection, where the lesion is, how active the lesion is. And then we stage the lesion, in which stage of cavitation this lesion is. And then we check for the risk assessment of that particular patient. After knowing all these things, we make a plan. We decide for that patient. Decision is into two phases. One will be at a patient level and second will be at a lesion level. But we integrate both the plans together. So for patient level and lesion level, we synthesize and we make a plan for that patient. And then after making a plan, we execute our plan. And that should be either surgical way or a non-surgical way. That depends upon in what stage the cavitated lesion is. But we try to be minimally invasive. We respect the hard tissues. That is according to the latest guidelines. Now, to check between active carious lesion and passive carious lesion, there are few guidelines, although we have already discussed about it. So if you find any plaque present, thick plaque present, you may suspect that a carious lesion, which is active one. And then if you find the enamel to be very matty and not very lusterful, and then you can suspect it is an active lesion. If you just gently move your probe and then you find that enamel or dentine to be soft or rough, you suspect an active lesion. And on a proximal surface, when you find a bleeding or inflammation of interdental papilla, you may suspect an active carious lesion. So, and this is according to the radiographic classification, which we talked before, like for E1 and E2 lesion. E1 means there is a radiolucency present in outer half or inner half. And then D1 will be just cross the dentinal enamel junction, and D2 and D3 are already there. So my presentation will be purely till D1, right? Because once it is D2 and D3, the studies say there is always a loss of surface. There is already a cavitation. But in some cases, some recommendations are there that even at D2, if you are able to clinically examine the proximal surface, even still, you don't need to do the treatment. Because if you clinically examine the proximal surface by using, by opening up the proximal surface by using your separators, ortho separators, definitely if you look at the proximal surface and you don't find any cavitation, then you do not need to restore with any restorative material. We can rest the lesion there and put the patient for follow-up. But for D1, till D1, the studies say there is no cavitation. The surface is intact. So you do not need to prepare a cavity. When you, on a radiographic X-ray, you find a radiolucency just crossing dentinal enamel junction. You can do these measures. For example, resin infiltrate. You can use fluoride varnishes. You can use a resin, these proximal sealants, and then you can apply topical fluorides for that patient. You can advise the dietary modifications. You can advise the patient to maintain oral hygiene. So many things we can do. We will just discuss one by one what all we can do. So till now, we have come to know that caries is not a continuous process. It is a process which can be reversed anytime. We just need to modify the factors which are responsible for decalcification. And this is a fact, a standardized fact. This all of us, we know that there is a critical pH for decalcification of enamel, that is 5.5. So, but when you apply fluoride or ions for recalcification or remineralization of a subsurface carious lesion, this will lead to formation of a fluoroapatite. And fluoroapatite demineralizes at a pH less than 4.5. So you can see normal hydroxyapatite will demineralize at 5.5, but fluoroapatite will uh, demineralize at 4.5. And bringing 4.5 in a clinical setup is not at all easy. So that's the reason once you remineralize a decalcified enamel, the enamel becomes such a strong enamel because of presence of fluoroapatite that it doesn't decalcify. And that's the reason the recalcified lesion is more stronger than the normal enamel. Right. So we just, this is a Caries imbalance. This is all given in 2007. So we just need to change the factors from harmful factors to the protective factors. So something about early detection of decalcification. We all know various diagnodent and all those. I'm not going to go into the details of all those gadgets which are responsible, but just something I could find on internet or few of the articles when I was searching for the management of caries. So this is one gadget which is based on a principle that any loose calcium onto the surface of tooth will emit light with the presence of photoproteins. So what they do is they use photoproteins. So these are the photoproteins, and this is the gun, which is the gadget which is there. So they apply photoproteins onto enamel surface wherever a decalcification is suspected, and then a picture is taken up. And then I will show you the few of the pictures which I've taken from their website. So this is a syringe for the photoproteins, and once on an enamel normal occlusal surface, they will take a picture. That is a pre-procedural picture. Then this is the picture, like normal picture. Then they will apply photoprotein using this same gadget, and then immediately after applying the photoprotein, they will again take the picture, and this is how you will find active decalcification going on, demineralization going on. So that is the basic principle of using. So this is how you can see active decalcification going on. And best thing about this product is that it doesn't make the bound calcium eliminate. It doesn't. So the bound calcium will not produce a light. Luminance won't be there. Only the loose calcium which is there after decalcification, that will eliminate. So this is a software they have. So once you click a picture and you can see it. Then so remineralization of initial carious lesion and reduction in cariogenic bacteria, because we know that biofilm is responsible for, and in biofilm the harmful bacteria are responsible for causing caries. So apart from recalcification, we need to tackle the bacteria by using chlorhexidine, diamine silver fluorides, ozone applications, triclosan, and cavity seal by chemical material adhesions. Because when you seal the cavity, when you apply pits and fissures, what happens? Whatever the bacteria is there inside the pits and fissure, they do not get food supply from the oral cavity, and no one can survive without food. So ultimately, those bacteria have to die. So that's the rationale behind using pits and fissures, apart from mechanically sealing these pits and fissures. So remineralization is a process by which we supply calcium and phosphate from an external source to the tooth to promote iron deposition into the crystal voids which are there in the hydroxyapatite because of decalcification. So we just supply calcium and phosphate to the. So this is one of a beautiful article which is there. This article has been published by Department of Pediatric Dentistry, Mahe, Pondicherry. So this is one of the article in which all materials which are available almost till now have been included, except one or two have been included. So you all can read through this article and you will get lots of knowledge about all materials, their mechanism of action that's there. And few of the studies they have also mentioned. So we have what are the minimum requirement of a remineralization process to occur, because there has to be a significant amount of minerals present into the saliva. If these are not available into the saliva, how recalcification happen? And all these activities should occur in close proximity to the demineralized spot. If suppose demineralized spot is somewhere else and the minerals are somewhere else, it won't be effective. So the minerals should reach to a demineralized spot for action. And the spot of the tooth has to be clean. If the spot of the tooth is covered by a biofilm deposits, then recalcification can never occur. So that is the reason it is important to brush the teeth properly or clean the teeth properly before using any remineralizing agent. If we do not do, then it is not at all effective. Then there are few requirements of a remineralizing agent. Previously, in the previous slide, we have discussed about the minimal requirement of a remineralization process. Now we are talking about the ideal requirement of an ideal remineralizing material. So this material should diffuse onto the subsurface or deliver calcium and phosphate into the subsurface. If it is not able to give calcium and phosphate into the subsurface, recalcification cannot happen. And it should not deliver excess of calcium. It should give an appropriate amount of calcium, not less, not more. And it should not favor calculus formation. If it is favoring calculus formation, it is quite possible that lesion may be covered. And if lesion is covered, then it will not be effective. And it should work at an acidic pH, because we know any decalcified spot is because of acidic pH. And if this chemical is not effective in acidic pH, it's of no use. And saliva is an important thing. In patients, there is less of saliva, especially patients after radiotherapy, patients who are into some medicines, because maybe anti-anxiety medicines or maybe antihistamines, and because of some surgery has happened, or because of rheumatoid arthritis, Sjogren syndrome. So these kind of patients have less of saliva. They are xerostomic patients. It should work in these patients also. And it should complement the properties, remineralizing properties of saliva. So these should be the minimal requirement of a remineralizing agent. Now we have a list of remineralizing agents available, like fluoride, calcium phosphate, calcium sucrose, sugar substitutes, hydroxyapatite. There is number of remineralizing agents available in the market. Few may be available in one country, few may not be available in other country, because I don't know which all materials are available in Pakistan, because I think India and Pakistan are the same. Whatever is available in India, I think the same things are available in Pakistan, because I think most of the Asia, it's almost same. We have the same companies which are coming to our countries, right? So, but this is a beautiful meta-analysis. This is a study which has been done in 2019. According to this, the fluoride is still the best. So, sealants plus 5% sodium fluoride varnish, resin infiltrate plus 5% sodium fluoride varnish, or 5000 ppm fluoride toothpaste or gel are most effective for arrest or reversing non-cavitated occlusion, proximal, non-cavitated and cavitated root surface lesions, or primary as well as permanent teeth. So out of these chemicals, if I look at 5000 ppm of fluoride, so this paste is not indicated for children. This is only indicated for older patients who have a root caries. And this is not at all recommended for young children. But yes, 5% sodium fluoride, varnish, resin infiltrate, and these proximal sealants we can all use for our pediatric patients. Now, the problem with the fluoride vehicle is, if you simply use a sodium fluoride, say I talk about a simple sodium fluoride, what happens? Because of action of this sodium fluoride, only the superficial layer, the porous superficial layer will get remineralized, will get recalcified. Once the porous structure is closed, the pores are closed with remineralizing agent or this fluoride agent, the enamel pores are blocked. There won't be any exchange of ions between the body of the lesion, which is subsurface. So that body of the lesion will not get full calcification. So full remineralization will not be achieved. That is a main problem with a simple fluoride vehicle. And to counter that, we have acidylated fluoride products. Because in this, there is a less pH. It is acidic. So because of acidic pH, the ions do not just remain on the surface of the enamel, because the blockage of enamel will not happen. So if the blockage will not happen, then full calcification of the body of the lesion will happen, right? So, and apart from that, this acidylated phosphate fluoride, what it does is it releases calcium and fluorides associated with bacteria. And because it releases calcium and fluoride, which is associated with bacteria, and that is also responsible for deposits of calcium and phosphate into the tooth surface. So that is the mechanism of action of that. Then we have a curodont repair. I don't know it is available in your country, but in India it is not available, because this is available in Switzerland. But just for knowledge, because sometimes you have to write an answer on latest remineralizing agents, just for your knowledge. But yes, it is available in many of the countries. So basically what happens when this monomer is applied to an early carious lesion, it diffuses into the subsurface micropores into the lesion, and then it attracts calcium and phosphate from saliva. And with that, there will be formation of a crystal, which enables the regeneration of lost calcium from enamel and dentin. Then we have arginine technology. In this, we have calcium carbonate is there, then fluoride is there. This fluoride is in the form of a sodium monofluorophosphate. So what happens when this material is applied, 1.5% arginine is applied onto the tooth surface, it produces ammonia, which is very, very highly alkaline. And because of this high pH, right, what happens, the calcium which is there in the form of a calcium carbonate, that gives a calcium to the demineralized lesion, and fluoride will be provided by a sodium monofluorophosphate. So these only two components we need. But as such, arginine is directly not responsible for making a decalcified lesion a remineralized one. Then we have tricalcium phosphate products. Yes, these products are available. I think it is available in your place also. So in this product, what happens, there is an organic material as one of the component in this. Because of organic component, the calcium and fluorides do not react with each other. If the calcium and fluoride is formed before we take it to the tooth surface, then this material is not available to be taken up. So that is the reason this organic surface does not allow the calcium fluoride to be formed, keep them separately and available for its action. Then we have a bioactive glass. This is also available. Many toothpaste are available with a bioactive glass now. In India also it is available. So this contains fluoride, strontium, potassium and zinc, and in one molecule all these components are there, but the active components are calcium, phosphate and fluorides. So all these components are available in a single glass component. So when these are applied to the tooth surface, the calcium is immediately released, but the fluoride is released over a period of 12 hours. So because since the fluoride doesn't react with calcium fluoride, and that's what we need, and calcium and phosphate will get impregnated, and then the fluoride will be impregnated also. That's how this is calcified. Then we have a ready-made preparation with hydroxyapatite. We all know enamel is formed of hydroxyapatite products. So once we give a ready-made preparation, a noble hydroxyapatite and fluoride to any demineralized region, it will take up, the lesion will take up this material, and this will act as a template on which larger amount of calcium and phosphate from oral fluids or is deposited onto the lesion and leads to recalcification or remyelination of the lesion. Then we have a theobromine. It doesn't contain any of the component of what you call remyelinizing agent, but because it induces increase in crystal size and it improves the crystallinity of hydroxyapatite, and because now we have calcium and phosphate into the saliva, so that is basically taken up from the saliva. But theobromine itself directly doesn't have any of the remyelinizing agent. Then we have a calcium glycerophosphate and this sodium monofluorophosphate. So that is also available for use as a remyelinizing agent, and this contains sodium fluoride because there is another variety, that's X-Clear toothpaste and rinse, which contains sodium fluoride, but Spire toothpaste and Spire oral rinse, that contains calcium glycerophosphate and as well as a sodium monofluorophosphate. So this is also a remyelinizing agent. Then we have this is a very common product which is available as a GC Tooth Mousse, GC Tooth Mousse Plus. So this is a casein phosphate phosphopeptides, and this contains CPP ACP, and basically this provides calcium and phosphate for the surface. And this GC Tooth Mousse Plus is recommended after 7 years of age, and GC Tooth Mousse alone, which it doesn't contain any fluoride, that is used before 7 years of age, because the children doesn't know how to spit. They will just, and it's tasty also, the kids will eat it, so we don't want toxicity to happen. So that's the reason we just give a normal GC Tooth Mousse to be applied onto the tooth surface twice in a day after brushing, and preferably when they go to bed, and because during night the salivary flow is less, so it's more effective. So that's what we advise to the patient. And then we have a AAPD policy regarding this about xylitol. Xylitol chewing gums are used worldwide as a alternative sugar or maybe in a caries management plan. But there are mixed kind of studies, because according to many studies, it says that you need a larger doses, and very frequently you need xylitol to be effective, and this cannot be used for children, very young children. So that's the reason it has a limited role, but further research is needed to reach up to some diagnosis, like how frequently we should use this xylitol chewing gum and what is the optimum dose to reduce dental caries, so that the health of kids could be improved. Then this is something by Shofu. This is SPRG. It contains many minerals, and basically this makes the acidic surface alkaline. When it comes in contact with water, when these SPRG fillers come in contact with water, then the surface becomes alkaline, right? So, and this effect is brought by all these minerals which are present. And then there is a fluoride releasing coating material. This is there into that, and this material is manufactured by Japanese people, by Shofu company, which is a very I mean, brand is there. We all use Shofu products as far as GIC and composites and so many other materials are concerned. So basically this material was to suppress the dentin hypersensitivity and also to prevent caries on smooth surface areas. So that's the reason, that's why it is applied onto a smooth surface, not for the proximal surface. So there are a few studies. This study was done in Japan, also Japan only. So according to that, if you make a coat of it, and along with fluoride application, so it has a more beneficial effect on white spot lesions. So it is effective material for remyelinization, and this material is still now, to my knowledge, it is manufactured by Shofu people. So this is another study in which toothpaste, it has been added into a toothpaste, and in that also It is effective. It is proven that it is effective in preventing tooth mineralization than 1100 ppm fluoride alone. So if you mix it, it is more effective than the fluoride again. So these are the recommendations in nutshell for arrest of or reverse of incipient carious lesions, that we can use a sealant plus 5% sodium fluoride varnish, or sealants alone over 5% varnish, 1.23% APF gel, which should be applied every 3 to 6 months. Then resin infiltrate. I will just share with you what resin infiltrate is. So, but every 3 to 6 months we have to use fluoride varnish or APF gel if we want to arrest or reverse the non-cavitated lesions. That's for the primary teeth. And then once in a week, under the supervision of parents, you can advise 0.2% sodium fluoride varnish, but this is not recommended for very young children because of fear of toxicity. Then for the permanent teeth, same protocol we should follow. For permanent teeth also, use of 5% varnishes or APF gel or a sealant or a resin infiltrate, we can use that. Then this is for the cavitated lesion for the proximal surface. For the proximal surface, same 5% sodium fluoride varnish, resin infiltrate, could be alone or it could be with 5% sodium fluoride varnish or sealants alone, right? And for the facial surface or the lingual surface, same APF as well as sodium fluoride. So now we'll talk about something about the resin infiltrate. Let's see what it is. So basically, resin infiltrate is a very low viscosity resin. It's nothing, it is just a low viscosity resin. The rationale behind using is because we know enamel is porous structure, right? And into that porous structure, if we are able to penetrate something and we can block the penetration, further penetration of the acid which cause caries, we can stop incipient carious lesion without doing any drilling. That is the rationale behind using this. So this technique is indicated till D1, that we have already discussed, because we know that till D1 the surface is intact. D2 there may not, surface may not be intact. But yes, if you are able to open up the surface by using orthodontic separators, and you find on examination that surface is intact, although it is D2, still you can try these principles, these processes, right? But otherwise, the D1 is the right stage. So for example, we have a proximal carious lesion. So this is one of the gadget which is there into the box for proximal application of a resin infiltrate. So it has a white side, it has a green side. So wherever you want to apply this resin infiltrate, the green side is kept to that side. So you can see a very fine filament-like thing in between the prongs of this gadget. So through this, the resin is applied onto the incipient carious lesion, right? But this is not a firm thing. It needs opening up. We have to open it up if there is no space between the proximal surfaces, and then only it will get into the proximal surface. So there are three things which are available into the kit, main three components which are there. One is the etchant, and second is the drying agent, and third is the resin infiltrate itself, right? So for example, we have decalcified lesion. You can see this is application of hydrochloric acid. This is applied onto the tooth surface, and then it is rinsed off, and this is normally applied for 3 minutes. That's a long period, and then it is dried. You will find a very chalky areas, and then you apply before that, here we apply ethanol. This is a drying agent because it will further dry the pores which we have created by using hydrochloric acid. So, and this will make the pores receivable for the resin infiltrate. The moment you apply a resin infiltrate onto the decalcified area or etched area and dried area, immediately it will be sucked into the through the capillary action, and it has to be applied for at least 1 minute, and so that it goes into the pores, and then it is cured 40 seconds, and then you replenish it, you retouch it for 1 minute more, because once you cure it, because of shrinkage, the material will be sucked inside. So you have to top up again reapplication of resin infiltrate for 1 minute, and then you cure it, and then you can see all decalcified areas are eliminated. And because there was a etching, there was a pitting present, so you can restore that pitted area with composite. You can do the composite. So now we have a systematic review which was done in 2014. According to that, you can see it is an effective method to arrest progress of non-cavitated carious lesions. So this is not indicated for cavitated lesions, purely for non-cavitated lesions. And then we have Pitts and Fisher sealants and preventive resin restorations. I'm not going to go into the detail how we do it, but just for information, this was important to make you understand. Like whenever we find the tooth into erupting phase, and like this condition is there, and we know that you are not able to isolate the tooth, and you cannot apply Pitts and Fisher sealants which are resin based, because for resin application you need a strict dry field, isolated field, and but in this case you cannot. But we, from the history of the patient, we know that patient has a high risk for caries, and if you do not apply it on time, there may be a cavitation. So you want to avoid the cavitation, you want to apply Pitts and Fisher in such patients. So for the time being, you can use glass ionomer sealants, because these glass ionomer sealants do not require that much strict isolated field. Some kind of moisture they can tolerate, and but a follow-up is important, because sometimes it fails. So follow-up is important, and it doesn't have a very high wear resistance. They are abraded off easily. So you can just put up the patient to follow up and let this tooth erupt, and then maybe you can switch over to resin infiltrate. So basic principle of application of Pitt and Fisher sealant is you want to seal off the pits and fissures which are infected from rest of the oral lesion. So once it is separated from the oral environment, the bacteria which are causing any infection, they cannot get a food supply, and ultimately those bacteria are going to die, and the caries arrest will be there. So that is the rationale. So now something about the silver diamine fluoride, which is in now. Although this is used since thousands of years, if you go into the literature. So many countries were already using it, but now this came into existence a lot. It came into the picture a lot, came into the news a lot, because American FDA approved it for use as a desensitizing agent, right? So once it was approved, so many other countries started following it, and many other dentists started following it. So if this material, if we compare it, like between the glass ionomer and this silver diamine fluoride, like how we can use it? Can we use it in a same surface or same lesion? There was a study about it. According to this study, if these materials are used together, or if we use a glass ionomer or this silver diamine fluoride, definitely they can help the patient, because both will give a fluoride. But if you compare a silver diamine, if you look at the studies which have been there about the silver diamine, this is amazing material, and there is no comparison as far as the arrest of the caries and prevention of caries is concerned. But the only drawback is this material makes everything black. That is the major drawback of using this material. But wherever we are not able to give a treatment because of certain factors, maybe the patient is not cooperating to you, maybe a very young child or very special child is there, especially in this era when you want to avoid doing aerosol dentistry because of certain guidelines of different countries, then you can use this material to arrest caries, you can buy time, right? Suppose the patient is having a medically compromised condition and you cannot do the treatment. The patient is on a bed. He cannot be brought to your operatory, and then in such conditions, you can use this material to at least arrest the carious lesion, carious process. And this material contains silver, ammonia, and basically fluoride. And silver, as we know, it's a worldwide, uh, I mean, accepted antimicrobial. This is also one of the component in many of the medicines. Like for burns, if I talk about silver, sulfadiazine cream is available, which is effective against pseudomonas. So this is available. Like this is available in many. I mean, available is as one of the component in many of the medicines because it has excellent antimicrobial properties. Basically, it arrests the decay, it prevents dental caries, and it decreases dentinal hypersensitivity. And if we look at one of the study, the effect on the microorganisms or into the biofilm, and this is one of the picture for Streptococcus mutans, you can see how effective it is in reducing the number of microorganisms. And then about the dentine before and after treating with silver diamine fluoride. This is one of the study which has been done, and you can see how effective is, how the change into the dentine is there. There is no dentine tubules after this application. The dentine becomes absolutely hard. So this treatment is for, this is indicated for pre-cooperative special children and wherever you want to delay the treatment. And this silver diamine fluoride contains 44,800 ppm of fluoride and 250,870 ppm of silver, such a high amount of fluoride and silver. So this fluoride reacts with the, because we know that fluoride is a remelancing agent. It provides the minerals to the decalcified dentine or to the enamel, right? So that's what is the role of fluoride. And then this silver will kill all the bacteria and it will stabilize the dentine. So once the bacteria are killed, there is because of fluoride, there is a recalcification of a demineralized lesion. So you get a hard dentine and less hypersensitive dentine, less sensitive dentine, right? And a few of the studies are there. I have quoted here. According to that, even 96% caries arrest is there. Even prevention is 70%. If we compare it with fluoride varnish, and you can see arrest is 21% and prevention is 58%. There is a significant difference between SDF as well as this. There is another meta-analysis, and caries arrest was 89% higher than other material. So the use of SDF is very, very simple. Simple means it has to be just taken care that the silver diamine fluoride should not touch anywhere else other than the cavity. Because if it will touch the skin or the gingiva or the soft tissue, it will cause either ulceration and definitely it is going to stain that area. Although it is a reversible one, but it is embarrassing for the dentist as well as for the child or any patient. So whenever you apply, use it consciously that it should not touch anywhere else. And whenever one drop is more than enough to treat 5 to 6 teeth, and accordingly you can dispense. And we must use a micro brush, sponge brush for applying it, and it should not be fully wet. It should be dabbed before you take it to the tooth surface. And petrolatum jelly has to be applied onto the lip, onto the surrounding gingiva, so that it is well protected. And you must use high vacuum suction and cotton rolls for isolation. And this is one of the consent form which is there on APD website. You must get this consent form signed, because some patients may say why the tooth has become black. So we should inform that there are treatment options available, but since this is not the right time for that, this is one of the option. And later on, maybe when we have a time or when we can really help this child or any patient, we can go ahead with the treatment. So prophylaxis, Vaseline, relative isolation, Then gentle drying is important. Use high vacuum suctions. You apply with a micro brush, a micro sponge brush for 2 to 3 minutes. Then what I prefer is I always use Floritop SR varnish we have in India. I think same kind of fluoride varnish must be available with you there. So you can apply this varnish because that will mask the taste. And then you can just wash it with water and give a standard instructions post-operatively. And there is no restriction onto the number of applications. But the studies say 2 times in a year is good enough, but it depends upon the risk assessment of the patient and because of the whole hygiene and the diet pattern and all that. So that can be anytime decided depending upon the risk assessment in future. Then this is used for extreme caries experience and wherever there is a behavior or medical management challenges. And whenever you are not able to treat that lesion easily, it's difficult to treat, and the patients who cannot come to the operatory, and very young children who are waitlisted because of some reason, and in those patients you can use. Contraindication is not much, only the silver allergy. Any of the component, if the patient is allergic, we should not use. And the tooth who do not have a good amount of remaining dentin, who are deep, whom you suspect to be pulpily involved or near to pulp, should not be the candidate for SDF application, right? And then you have to make the application by using petrolatum jelly so that it doesn't touch the soft tissue. And safe, it's absolutely safe. If you look at the safety margin, 1 drop, because I have already discussed that 1 drop is more than enough for 5 to 60. In 1 drop, there is 9.5 milligram of silver diamine fluoride. And but this is absolutely a safely tolerated dose, no problem with that. So it has 400-fold safety margin. So no worry, because published clinical trial is 4,000 young children worldwide, no reported case of death or any systemic issue. So the adverse effect will be the black discoloration. Everything turns black, but wherever you touch it, there will be a temporary staining to the skin, which will take few days to go. There could be a minimal mucosal irritation wherever you touch it. It will get resolved, but yes, sometimes it is painful. And in larger doses are not allowed, recommended in very, very young children. But yes, for adult patients, older patients, you can apply it more frequently also if the need is there. So whenever there is a deep lesion, do not use this material. So only the asymptomatic treat where there is no pulpal involvement, there is a significant amount of dentin present, remaining dentin present. So on those patients, those teeth you can use it. So this is because we know that it stains everything. So if it spills, you have to rinse, but nothing will happen. Only thing is it will just take few days to go. So now there are and a few of the studies are there. According to this study, it is a proven fact that SDF is more effective than this sodium fluoride. And then many people, even one of the company in Europe, they will use potassium iodide dyed also along with the silver diamine fluoride, that is for reduction of staining. But potassium iodide is not recommended for pregnant females because of problem with the thyroid issue. So this is not recommended for in pregnant females, but yes, in others we can use. And there is a mixed response of this potassium iodide, because there were 6 studies according to this systematic review which has been published, and there is a mixed kind of response. So insufficient evidence exists supporting the clinical benefit of SDF and potassium iodide, but still more studies are needed. But yes, it reduces staining to some extent, but this meta-analysis has been done in January 2020. So there are SDF AAPD guidelines you all can download and just go through the guidelines which are there. And Take home for SDF is it arrests 90% caries when used twice in a year. It has an indirect prevention, dry before use, and it stains everything, whatever you apply. In nutshell, for primary teeth, if we divide the corneal surface, crown surface into occlusal, approximant, and facial lingual, then the recommendations are we can use 5% sodium fluoride varnish or 1.23% acidated phosphate fluoride or resin infiltrate along with 5% sodium fluoride or 0.2% sodium fluoride varnish every week, but not for younger children. Even in children, it has to be supervised, right? And for a cavitated lesion, this was for non-cavitated lesion. For a cavitated lesion, 30%, 38% silver diamine fluoride. There were also studies to use a lesser percent of silver diamine fluoride, like 12% silver diamine fluoride. But according to those studies also, 38% silver diamine fluoride is much more potent to use as a caries prevention or caries arrest than using a lesser percentage of silver diamine fluoride. And for the permanent teeth, almost the same guidelines are there. For the non-cavitated lesion, you can use sealants plus 5% sodium fluoride. And if not possible, if you cannot use sealants, you can use 5% sodium fluoride varnish, 1.3% APF gel, or 0.2% sodium fluoride mouth rinse weekly, right? But for the root surface, because you may be getting many patients who are old, who have root caries, in those patients, 5,000 parts per million fluoride toothpaste is to be used. And if you cannot, then you have other options like fluoride varnish, SDF plus potassium iodide, or may not be only SDF, may not be with potassium iodide, or chlorhexidine 1%, along with 5% thymol varnish as an antibacterial. And then this is in conclusive. For the biofilm, the oral hygiene, the antimicrobials like chlorhexidine and probiotics, and for nutrition factor, that if your target is nutrition, then dietary modification, and substitute your sugar with other dietary substitutes. Then for mineralization, you can use fluorides, calcium, phosphate components, different things are there. For stimulating saliva, because saliva itself is a buffer, cleanser, and antibacterial, so many, and remineralizing agent also. So you need to use chewing gums, xylitol chewing gums. For giving a protection, a diffusion block, you can use a sealant or a resin infiltrate. That is a micro-invasive treatment. And if sign and symptoms of the disease, that is a cavitation, happens, then restoration has to be done, but restoration has to be done with the minimal invasion. So now, if I conclude that, I will conclude that early and correct diagnosis of carious lesion is very, very important for giving the best treatment to your patient, right? Then identification and monitoring of bacterial load of the biofilm is important. Diet analysis is important. Diet modification is important. Use of topical fluorides, use of antimicrobial agents are very, very important. Now, new technologies are coming up, like we discussed few of new technologies. And so with all the knowledge of these new technologies, we can have a different approach and intervention for the management of dental caries. And these are the few of the references which I've used for preparation of my presentation. And with that, I really thank you all. And I thank Association of International Dentistry and Dr. Malik for inviting me on this platform. And I'm really honored to be a part of this. And I look forward to see you again sometimes. So if any question is there, I can, let me check.
Thank you so much, Dr. Vrinder. Actually, if anyone has any questions, you can raise your hand. I will unmute you. You can ask directly, or you can place your question in chat box. We will forward to Dr. Vrinder. He will answer.
Let me just go through the chat. I think few of the chat is there. No, I don't think there is something. Regarding sealants, are we supposed to seal the tooth surface which has remained caries-free in the cavity for years, according to the latest guidelines? Yes, Dr. Cosma, thank you for this question, because it all depends upon. Am I audible?
Yes, yes, you
Yes.
are
Okay.
audible.
Actually, it all depends upon the risk assessment of that patient. Like suppose today I'm a patient, I was caries free, I never had a problem till I reached 48, but suddenly I developed some problem. Maybe I have anxiety neurosis. I'm taking some medicine for my depression and for my anxiety. What they do is, because of that, I'm not able to do my routine work. I'm into a habit of taking lots of snacking because of my anxiety and all that. And because of that, I have a particular habit of taking lots of sugar. And then suddenly my change in biofilm is there, right? And then what happened, even if I was caries free for 49 years, I can be a patient in future. So that's what is caries management plan. I do not have to look at, as a dentist, just finding the lesions in the mouth. I have to find the infection in the mouth. If I am able to find the infection by taking a detailed history of the patient, the medical history of the patient, dental history of the patient, examining the patient, going into detail of the diet pattern of the patient, going into detail of the oral hygiene pattern of the patient, like, and the any systemic disease which can cause dental caries. If I am able to look into all those factors, at least I will be able to reach up to some diagnosis, some conclusion. Yes, there is this patient is now prone to dental caries and needs this kind of treatment. And now intensity of the treatment will depends upon how much risk assessment is there. Is it a mild one? Is it a moderate one? Or I'm at a high risk? So all those factors, depending upon all those factors, my treatment plan will be. Dr. Anirban Chatterjee, yes, Dr. Anirban, whenever the question is how we manage of any extent accidental exposure of SDF on mucosa or epithelial burn. Dr. Anirban, whenever it spills off to the mucosa, we have to immediately rinse it. That's what you can do. But if already a burn is there, you can just give a palliative treatment, because this lesion, burning will go, I mean, this lesion will go within 2 to 4 days. But if there is a staining, this is going to take a lot of time. And Dr. Deena Rabia has mentioned that, is there any dental research like meta-analysis done into diet analysis and modification? Yes, Dr. Deena, there are a meta-analysis done into the diet analysis and modification. And since we are connected with each other already through on my WhatsApp, I have your number. So definitely I'm going to share the PDF with you, few of the PDFs which are there for in this regard. Definitely I'm going to share it with you. Dr. Shreyas, your question is how much time to wait after SDF application for crown cementation? The studies say there is no problem in the bonding. There is no problem in the bonding. Even you can do whenever you want to. But for GIC, yes, we can immediately do it. But for composite, it's better to wait for 7 days, right? So, but otherwise, the studies say there is no, because I can share. Even Dr. Shreyas, you are connected to me through my WhatsApp. So even I can share that one study which I know, which doesn't say that there is any problem with the bonding if you use SDF, and even you can use in a routine, right? And then Dr. Dr. Naib, how high amount of fluoride in SDF won't harm the primary teeth? No, Dr. Naib, whatever fluoride we apply onto a primary tooth on a dentine or a carious dentine to arrest decay, that doesn't get penetrated into the primary tooth, like it doesn't cause any systemic effect. It will only be absorbed onto the dentine and to the surrounding enamel, and it will definitely makes the dentine hard. So it has no systemic effect unless it is ingested or it is used in a very, very high amount. Dr. Madho Sai, can we use SDF for prevention instead of sodium fluoride? SDF has its own role, as we have already discussed, because SDF makes everything black, and all parents may not like to see, or patient may not like to see their teeth black. But if they understand this and if they agree with it, definitely SDF is a better, much better preventive tool than sodium fluoride, definitely. Dr. Sandra, your question is, can resin, no, sorry, do we use chemical-mechanical removal of caries lesion? Yes, Dr. Sandra, we can use this CMCR for caries removal in the lesion. But since we have talked about incipient carious lesion, today we talked about only the non-cavitated lesions. So that's the reason I have not taken up my chat has gone. I have not taken up this CMCR for this particular topic. But yes, we can use this for removal, especially in young children, and especially as a part of non-aerosol dentistry during this COVID period. Yes, we can do that. And Dr. Jenna, yes, we can apply resin infiltrate for smooth surface lesion of posterior teeth also, apart from proximal surfaces. Even for the interiors, wherever we have done orthodontics, and after removal of brackets, we see a decalcified enamel, we can use resin infiltrate in such patients. Even I can.
Okay. Yes, you can continue. You can continue.
Okay.
No,
so actually, my chat was going off in between, so I was missing few questions.
I will forward you.
No problem. No, I can. I was yes. Let me go back then. Yes, Dr. Jenna, we can use a resin infiltrate on smooth surface of posterior teeth. Yes, we can do that. And Dr. Arpita, you have mentioned, sir, what according to you is the best material regarding the micro-invasive dentistry? Dr. Arpita, it is not only one material which is the best material, I'll say. If I talk about the results of as a remilling agent, as a caries arrest, SDF certainly has the edge over all that. But since it cannot be used in all conditions, then we have to choose the material accordingly, according to the need of the patient, according to the caries risk assessment. That is important. So caries risk assessment is the main thing on the basis of what you can plan or your treatment, right? So that is very, very important. So even if you want to discuss, yes, anytime I'm available, because you already have my phone number. Dr. Suraya, thank you so much for your greetings and wishes. Dr. Sharon, you have mentioned about how much ppm fluoride has the best effect on the tooth surface. I have given you in nutshell, like what are the recommendations by American Academy of Pediatric Dentistry. That is 5% sodium fluoride or 1.23% APF we can use as a topical agent, and we can also use 0.2% sodium fluoride mouthwash weekly, and we can also use 5000 ppm containing fluoride for a patients who have root caries. So now, depending upon what is the condition, you can choose. That's what, right? Dr. Abhijit, your question is, sir, in regular practice with SDF, how should we go about discoloration at a later time? Crown composite or any other method? Yes, Dr. Abhijit, it is called a SMART. It is basically a smart technique we can use. That is a silver modified ART, atraumatic restorative technique. That is called a SMART. So even after application of SDF, you can use glass ionomer as well as composite to mask the discoloration. And even you can go ahead with crowns to mask the discoloration. But since we are using SDF for those patients who do not have access to the dental care and who are medical compromised, who are special children, who have a high caries risk, and you want to use it for young children, uncooperative children, because that is what is meant for. But yes, you can use it for multiple other options, like to arrest the decay before you place a crown. Yes, we can use that. Definitely we can use that. What about the dust control? Dr. Sarwar, you have questioned me about the dust control during cavity preparation in COVID situation. See, for us as a dentist, fortunately, whenever we are preparing a cavity, and if we are using a rubber dam, then you don't need to worry at all, because the aerosol which will be generated will not have any infective agent. It is just a spray of water and air. So if you are using a good quality isolation control with a rubber dam and with a pre-procedural mouth rinse, and then I don't think there is any point to worry. The problem is only when we are doing a crown cutting and we cannot use we cannot place a rubber dam. Definitely that is a issue. So recommendations are use four-handed dentistry, use rubber dam, use pre-procedural mouth rinse, and you can use a high vacuum suction. High vacuum suction means real high vacuum suction. So that is what is recommended. And then there is a question from Dr. Madiha Khan. Sir, does potassium iodide will change the properties? And no, it doesn't change the property of silver diamine fluoride at all. But yes, it makes it causes the less discoloration. There are studies that it does not changes. The only problem is we cannot use it in case of young pregnant females. That is important. And Dr. Noll, yes, we should use maximum 1 drop of SDF per visit, and that is sufficient for 5 to 60. That is sufficient for 5 to 60. So that 1 drop is enough for children patients, right? And then Rupakshi, thank you so much. Arpita, you have mentioned about, is there any disadvantage of using resin infiltrate? No, there is no disadvantage of using resin infiltrate. You can use, but yes, it has a selective indication. You have to use it as per recommendations. That's what, but otherwise there is no disadvantage. But only problem is the people who are allergic to any of the component. Yes, we cannot use this material onto those patients. Then we have Dr. Yashwant, you have asked about any adverse effect as other than SDF. No, there is no adverse effect other than the staining, apart from if the patient is allergic to silver or any of the component. Yes, or if there is an ingestion or if there is an excess use, definitely for young children, it may be a problem. So accordingly, you have to use it judiciously. And then we have, I have already answered these questions. How much time? Okay, no, Dr. Shreyas, I've already answered. Dr. Deena, I've already answered. For Dr. Cosmas' answer, I've already given. Yes, Dr. Costanza, thank you so much. I know you're always there for me. Thank you so much for being there. I think I have already answered all the questions which were there. And I don't know about the Facebook. Okay, one more question. Janri has mentioned, she's our postgraduate, and she has asked about the helozone. Janri, yes, we can use helozone for sterilizing the lesion. Actually, helozone cannot remineralize the lesion because it is antibacterial in nature. So whenever you flow ozone onto a carious lesion, it will kill the bacteria which are there into a deep pits and fissure or any plaque or any biofilm. But you have to use a good quality remineralizing agents after using helozone, because otherwise it will not be effective, because only killing bacteria doesn't make sense. We have to use remineralizing agents. other than using Helozone. That's what. This is, I think, over, and there is no question. If you have, Dr. Malik, any question for me from Facebook, definitely I can answer, but I don't know if there is any question because I'm not able to see the chat.
Thank you so much, Dr. Vrindergal. Actually, there is no question from Facebook. And they
Okay.
all are concerned about your lecture. They are highly appreciated.
Thank you so
Thank you
much.
so much. I have a request from all the audience. They can follow our page so that they can be updated with the quiz of this session. They will be able to get their certificates after attempting the quiz from our website. I have on our page, everything is mentioned. Contact number there is mentioned. There is mentioned websites also. You can visit and you can do everything from our website. Thank you so much.
Yeah, thank you. Thank you, Dr. Malik. I was getting so many messages on my WhatsApp also, but I'm sorry I could not answer. Maybe few of my friends may not have been able to join because of some technical issue, but I'm sorry for that because I was just busy in my presentation, so I could not look at my WhatsApp chat. Definitely, I'm going to reply to all of them. And thank you so much for inviting me once again. And I thank all my friends who are there today with me on this platform. Thanks a lot.
Thank you so much. Take care.
Please take care well, stay safe, stay healthy, keep in touch, and do inform me if I could be of any help to you. I could do anything for you.
For sure. Thank you so much.
Inshallah. Thank you. Bye bye. Take care. So may I leave, Dr. Malik? May I leave
Yes,
the, okay.
yes, I am ending the meeting. Thank you so
Okay.
much, everyone.
Thank you.